Thank you so much, Elmaadawi. شكرا انك قلت لي Elmaadawi. You say Elmaadawi all the time. اتشرف طبعا اول مره احضر المؤتمر ده، حاجه جميله جدا. واول مره ادي محاضره الساعه 9:30 مساء. لا يعني بس انا قبل ما امشي عبد الحليم طلع بعد ام كلثوم، فاكر انت؟ ولا قال لك انا طلعت متاخر؟ بس يعني هنحاول نختصر يعني. Well, comprehensive review is very hard for TMS. TMS is very growing science, and we'll go as fast as we can for the sake of time. So this is my disclosure. I'm running research for TMS for pediatric. I'm also a child psychiatrist. I work with pediatric mood disorder, and we have interesting results for TMS for kids. We're also running a couple of trials for pediatric antipsychotic medications and side effects. So what's the outline? هنتكلم عن ايه؟ هنتكلم عن mood disorder, depression, how we understand it. يعني احنا دلوقتي بندرس mood disorder للطلبة والريزيدنت ازاي، والعلم كلنا ايه دلوقتي؟ وهو دلوقتي how do you manage mood disorder, depression with TMS, and what is the definition of TMS? يعني في حاضرين كتير هنا. Raise your hand if you actually work with TMS before. I know you had TMS 2, 3, 4. Okay, so probably like 10% of the audience. What about raise your hand if you never heard about TMS, the word TMS before? It's okay. Excellent. Actually, some believe the resident never heard about TMS, and in the States, so it's all over. However, my thought is people with TMS experience, they may have some bias about how effective it is. So we know first, depression is very hard to treat, it's raising problem, it's going to be in 2030, ربنا يدينا طول العمر يعني، هيبقى رقم واحد في disability. وفي أسئلة كتيرة، طبعا سمعت زمايلنا يعني ودكاترة عظام بيتكلموا عن how we treat depression, for example, or mood disorder. Why you tell your patient it takes 4 to 6 weeks for the medication to work. You give the fluoxetine, it takes 4 to 6 weeks. Why that, right? And even with all the traditional treatment, it's still 2/3 of patients have partial response and 1/3 never respond. It's very easy to treat. If you are endocrinologist and someone comes to your clinic for diabetes and give him insulin, and you tell him this insulin is going to work maybe 60%, he will leave you and go to the other one, right? Insulin work 100%. Why at the providers in the mental health field can't provide cure? We just have the symptoms controlled, and we're only fully effective. But only this, same treatment, it could make symptoms worse or better. If someone has bipolar depression, if you give antidepressants, you could destabilize his mood. Same presentation, if you have MDD, you improve his mood. So symptomatology or phenotypical presentation or the DSM criteria for treating depression should not be the only way to diagnose and treat. So this slide, I'm sure everyone knows about it. This is how we teach medical students in medical school about the transporter, the serotonin and the norepinephrine. You actually have to, this is the pointer I guess, you have to SSRI, preventative uptake, or immune inhibitors. That is the classic, everyone knows this slide, right? That's how we teach how the medication works, right? And then you make your algorithm for treatment based on the slide. SSRI, then SNRI, then if the patient failed, you combine, you adjust, you add antipsychotic. That's a standard of care. We should not deviate from the standard of care, but we are not very successful based on this model. So let's talk about, and I'm sure you heard about the STAR-D trial. This is a famous trial that started in the 90s, funded by NIMH, to evaluate the treatment response one, it's actually done by primary care providers. Most of antidepressants prescribed, I don't know about Saudi Arabia, but most of the antidepressants prescribed by PCP. And then they come to us after complications. So PCP prescribing medication, we found out the more you try, the less likely to get response. And you actually had more hard time to control the depression, right? So you better get it right. Then let's talk more about how do we think about depression right now, the model. Depression is not just chemical imbalance. There is a part of depression run by electrical activity, the neurology aspect, the EEG. Our colleagues and neurologists who deal with this piece, we only deal with the chemical imbalance. However, the brain runs with two, ماشي بموتورين, صح? Electricity and chemicals. We only deal with the chemical all these years. However, when we do most effective treatment, as we know, standard of care ACT is actually run with electricity. So what we can see also in depression, there is anatomical changes. So there is a hippocampal changes, so there is cingulate guide changes. So it's not just the chemical imbalance. So now we have something that's called a neuroplasticity of the brain. And I'm sure most of you guys heard about neuroplasticity. The neuroplasticity is the ability of the brain to communicate and adjust based on the interaction of the neurons. I will still have the same accent, for example, like أنا بتكلم بaccent, not American, عشان لسه my brain is not fully neuroplastic. ابني اللي عايش يعني بيتكلم ليبل دلوقتي ليه؟ لأن هو brain is very, you could learn things in an early age. And as a child psychiatrist, we are very interested in neuroplasticity. How the brain could change, especially with depression, to adjust, even without medication. So the neuroplasticity, if we think about the brain and how neuroplasticity works, it's actually depression, it worked perfectly fine. It is the failure of neuroplasticity, not just or chemical imbalance. So basically, when we do this, there is even neuroplasticity markers. And again, the slides are long, and for sake of time, there is even markers now. So when I tell my patient, it is almost neuroinflammation. It's waxing and waning. Patient comes with seasons of depressions, and it's really, you could measure in CSF, you could see FGF or BDNF, you could measure in a CSF now, which is almost like لما العيان عنده lupus, we check the markers for it. So now there is markers for depression, and my colleagues talked about some markers of biological or endocrinological marker. So all this, so why we talk about all this for TMS? We talk about comprehensive review because I want to explain that TMS is not just like another modules or relaxing chair in your clinic. It's not like a fancy massage chair in your clinic. It is actually a treatment. It's now up in the hierarchy of treatment of depression because it induces neuroplasticity. Not just chemical imbalance, not just pushing the bottom, or a light therapy, for example, what I hear sometimes. So I'm running an interventional psychiatry program, and basically the basics, and I'm sure everyone knows about the basics of how the magnet from high school, يعني عندي نايت ميرز من high school في الفيزيكس اللي هو المagnet بيتحول إلى electricity. And Faraday, الأخ Faraday دوت اخترع the Faraday law, where the magnet transfers electricity. You could manipulate increased connection or decreased connection, right? So basically, that is the basics of TMS. Started since when? Since the 90s, 1990s, or 80s even. في بقى مشكلة يعني, we have to talk about this quickly, because, here we go. TMS, you can do anything with it. You could activate the brain, deactivate the brain, you could adjust the parameters, you could make the connection fast or slow. As you can see, you could have one pulse, train of pulse, like 10 pulses per second, 40 pulses per second. You have now actually TPS, which is theta burst stimulation, fast stimulation. So it's a own science. So I heard this a lot from colleagues saying, oh, I have a TMS, it's not really working. And I said, like, how do you do the treatment? And I found out they do different treatment than what's supposed to be. So I think what we tend to do right now, our colleagues in cardiology, they have the interventional fellowship for cardiology, they have interventional radiology. We should start something like interventional psychiatry fellowship, just for teaching TMS, ECT, and things like this. That's very crucial. And we actually started a non-accredited fellowship in our university, running just for teaching this. So TMS is used for a lot of things since the 90s. However, NeuroStar started, I mean, we have to give them the credit. They are the first company, took all the data and started to investigate for depression. We have the magnet who initiate MRI strength coil to create a chain of reaction from the prefrontal cortex going down to amygdala and create a series of responses. It's happening for 4 weeks, and then if you do functional MRI, you can see changes in the cingulate cortex where my colleagues talks about, right? So those actually changes happening and measurable. It's not like simple or transient. So NeuroStar started the biggest trial in early 2000 to get basically the depression indication, and it's approved by the FDA. So we had the patient, over 300 patients, over 23 states, and the treatment was done using the different double-blind study, and the treatment showing the efficacy data of the 56 to 60%. This trial, the NeuroStar trial, we have to, again, give that credit. I have in my practice multiple devices, by the way, so I have different manufacturers, but I have to give the credit to the first device, which is the NeuroStar, to get the approval by the FDA. Then later on, other devices got the approval. So that was approved by the FDA since 2008. It's approved by most of the insurance companies in the States right now. Medicare approved and Medicaid approved the TMS. Is it approved in Saudi Arabia, TMS? Excellent. Excellent. So it's really like it's non-invasive, no sedation needed, 300 pulses for 6 weeks. The patient will have no pain, no cognitive side effects. How many of you patients probably say, I don't want a shock therapy, I don't want to lose my memory, and they have this stigma about ECT. Or they confuse ECT with TMS. It's totally different treatments. One is inducing neuroplasticity and changing the connection in neurons, and the other one is almost like rebooting the brain. And we talk about ECT for another video. So for the next few minutes, I will talk about the durability. So you have a patient who had TMS. He responds. The question probably will ask you, how long will he feel okay? Like, how are the day كويس؟ أنا يعني هخف يعني ولا هرجع تاني ولا إيه النظام؟ Well, the durability data, we have the data now after 1 year of durability. We have outcome measure over 42 sites comparing the long-term durability of the 300 patients. We measure them 3, 6, 9, and 12 months, and we measure the quality of life for those patients. So, as you expected, what do you expect? How many you think will relapse? So, 50% you think? Anyone? Well, let's see. Okay, so this is actually a summary. 58% will do well, 59% will do well, 56% will do well over time in 1, 2, 3 months. Going down by a rating scale, if I go over here, you see here, we still 67% doing well. So, what? You do the math, 35% have relapsed, right? That's actually pretty good. I mean, I bet you, like patient, and those actually patient failed medication. So keep in mind, this is not a simple patient who just have antidepressant and that's it. he comes to you with TMS after he failed 4-6 antidepressant medications. So it is really like challenging patient. This patient is desperate. So the data comparing to ECT is actually remarkable. This is actually a true study, and that's why I tell my patient, 2/3 of patients who have ECT will need ECT within 1 year. So they relapse within 1 year. That's ECT data. Unlike TMS. TMS response may not as robust as ECT in the initial phase, but it's more durable. So if you know what you do, if you know exactly how much you get for TMS, the location, and you know the dosage, and how you actually, there is a standard of care that we started in our clinic and now became a practice guideline, and they took it in the Clinical TMS Society, and I'm going to share it with you in my slides here. Your actual response rate go up to 80%, not only 65 or 56. So now what I recommend from you guys, and since you have TMS, all of you, to have TMS part of this algorithm. Think about TMS once patient fail 1 or 2 antidepressants, because after 4th antidepressant, good luck. It's going to be only 25% chance based on a starting trial to actually do it right. So you will do it right from the first place and consider TMS treatment, because it's not the same like light therapy or vitamin D or take a walk, or patients say, is it like a massage chair and make me feel better? It is not the same. It is FDA approved treatment and has more durable data. So it's like a great physician, انتوا كلكم experienced psychiatrist. طبعا لما واحد لسه فتح عياده جديد بيقول انا gonna be a psychiatrist، هتقول له انت بتعرف تشخصه كويس، الدوز كويس، follow up كويس, all this stuff, right? TMS also is own science. It's not just having the machine. You need to consider the dosing, frequency, the power, side of side of treatment, هتعالج فين, number of stimulation per session, هتزود 3000 أقل أو أكتر, number of session, and are you going to give him medication or not? واحد يقول لك أنا عايز أوقف I'm feeling good, doctor. I had this many times. Patients actually, week number 4, feeling great. The cloud is lifted, and I feel like, oh, حياتي رجعت تاني. أنا خلاص هبطل الدواء. في الأول طبعا مش عارف ده العيان، فالعيان يبطل الدواء بقى من وراك. And behind your back, and guess what? He relapsed. So you need to make sure that the patient is honest with you. Or we have a problem, of course, drinking while we actually have TMS. This is not a problem in Saudi Arabia, but in the States, patient using marijuana or drinking or using a lot of substance that affect the efficacy of the treatment, or even the MT, right? Like benzodiazepine. If you give someone prescription of Xanax, your MT is messed up. So this is my data. So I'm going to share my data because I have device, like I'm working with TMS since 2009 actually. And I started my own working in Indiana in 2013. So I looked at 2015, 2018 data. Okay, this is actually, I looked at a snapshot, and I did this actually in the plane when I was actually flying to come to you guys. So this is my initial response rate because I didn't know much about TMS. I was just like having the device, like had my enough training, and 56% went up in 2018. The non-responder, 33% went on 15. So the combined 29 and 56, probably like 85%. So 85% response or remission together with my own data. And I start this refining the process, referral, see the patient twice between session, having the rule out patient with personality disorder. I don't know if you guys have a lot of patients with borderline personality or like the color, it's a big deal in the States, and they are big failures. Or patients who actually try to do TMS to convince the family, nothing worked for me. يعني عندنا ناس عايزة تتطلق، جايبة جوزها، أنا هعمل TMS عشان أثبت إن أنا بعاني ومش هتخف. يعني very interesting patients يعني. وأنا بقول لها يعني you are doing TMS to prove to everybody nothing gonna work for you. بعمل consult وبعمل assessment, بعمل مدرس handy. You have to have assessment scale in your clinic. You must. You have to have PHQ-9 by the patient. You have to. If the patient has an anxiety, do not ignore an anxiety disorders because it's a problem. An anxiety disorder, it could fail your treatment, and you have to treat the right side as well, even though it's not FDA approved yet. So let's talk about future TMS. I have maybe like a couple of minutes. So 3 minutes. Okay. So 10 slides in 3 minutes. Let's cruise over this quickly. We have a theta burst, which is a TPS 600 pulses. It's still not fully approved yet, but it's available. Accelerated TMS twice a week, twice a day. العيان ممكن يجي لك الصبح وبعد الظهر. This is actually an option. All this again off label. انت دكتور ومحدش بيقول لك امشي تبع الكتاب. بس انا I was trained in Mayo very traditional. يعني زي قوات مسلحه عندنا. Mayo Clinic بيقولوا if you do off label. Okay, so Mayo very traditional. Basically, if you prescribe off-label, you don't talk to us. Don't put your name on the prescription with Mayo Clinic because they're not reliable. So, someone depressed, prescribe depressed fluoxetine, especially pediatrics. Don't go and prescribe Paxil or something not FDA approved, right? So, if someone comes to you with, oh, I heard my friend who's doing TBS for 3 minutes, it's great. But did you try the traditional method first? So I tell people, try the traditional method first. That's what makes sense. Then if you fail, look for alternative treatments. So twice a day, patient, fight for traditional treatment. Okay? Other indication, PTSD, post-stroke, all these treatments, since I have another hat, I will actually cruise to the Mayo trial. I'm gonna obviously go over this, and we right now almost with the data. And autism, I have published with University of Louisville, talks about autism treatment with TMS is actually pretty promising. Finally, I made a summary. Can you see this table? That's kind of like a fun table. Don't quote me on this. We all like, لو انت عايز تعرف ايه تحط ايه فين وكام هرس وكده دوت it's initial table. This table it will give you the initial guideline. Try to do this first before you switch something else. Okay? So conclusion summary. The evidence suggests like mood disorder is not just neurochemical. There is epigenetic, neuroplasticity, neuroinflammation, like any other brain disorders. Interventional psychiatry is a new form of psychiatry now, like addiction, like forensic, like a child. We should embrace, we should teach our student and resident how to learn to use interventional device. Neurostar actually has been unique, and the first trial done by Neurostar for TMS and other TMS devices like follow this, and it's very effective for depression as we saw for the data. There is peer-reviewed long-term durability. Final quote, I wrote this down again in my way here. Successful TMS practice requires 10-10-10. Understanding how TMS work. تعرف ازاي؟ انا لو مش عارف البروزاك بيشتغل ازاي او الفلوكسيتين هكتبه وانا مش فاهم قصده. تعرف ازاي TMS how its mechanism of action. Practice TMS location. في حاجه اسمها في real estate. لو انت لوكيشن مظبوط ده احسن مكان في احسن قيمه صح؟ لو على البحر او كده. البرين mapping location is the most important piece. You do brain map and find exactly where you treat. Establish protocol. خلي عيادتك فيها protocol تمشي وراه. Follow this protocol, it will lead to success. Don't doubt yourself. لو انت عامل assessments بص على الداتا, evaluate your data. That's it. Thank you.
Thank you, Ahmed. We will open the floor for discussion. We have a few minutes on two, actually. So 1 to 2 questions maximum, sir. past?
Everything is clear.
Yeah. Yeah, sure.
That's kind of a tough one.
Great overview. Enjoyed that. Our TMS as first line, I want to kind of get your sense. I mean, how close do you think we are to? Most of the time we spend, most people on first medication, fail medication after medication. Where do you see the field at this point? Is that potentially going to come into play?
I think the more advanced of TMS device to make it like in-home TMS, you can take it home with you. Like that's what eventually going to be an easy access to the patient. The problem with TMS is the hassle for patient coming to your clinic, right? I have no doubt TMS could be used as a first line instead of $2 like fluoxetine or whatever. But the logistics behind giving a medication would not even cost time or money for the patient versus coming here and Monday to Friday, obviously. So once the technology to get to bring the device home, keep it home with you, not just, I don't believe much in TDCS, don't quote me on this. I know like TDCS actually, it's an 8 battery or 9 voltage battery, right? You can talk to give a battery, really like small total lag. It's pretty fun, but it's not as effective as TMS. TMS is actual treatment, it's MRI strings, like little MRI. So if it is actually make a portable TMS, that's going to be actually first line.
Thank you.
Good question though.
I have a question about location. For depression, it's clear, it's related to the prefrontal cortex. But for anxiety, for example, some clinicians say the best side is the right side, and some say it's the left side. For OCD, some say it's a cervical section, and some over the forehead. So I want to write your clinical experience. What is the best side for these two indications?
Right for anxiety, midline for OCD. Like, it's all about experience. So there is the most evidence, right? What's the most practice about right side, 1 hertz per second is the most accepted for an anxiety. The issue, networking, I mean, that's what I was talking to my colleague about, Johnson Downer. He's actually University of Toronto. He actually creates something called Salient Network, and I don't want to take too much time for you guys. This network is almost like Connect 4. It's going one direction, like move, this way or the other way. If you actually could prove the connection is one direction, you could actually treat the right side. There's a patient I treat on the right side with an anxiety, it gets worse. And when we actually asked my colleagues, the expert, we discussed, and they may actually want the rare patient. It's like a heart on the right side. There's patients have the networking is the opposite, anti-salient network. Where if you treat an anxiety, it should be the left and depression the right. Yes, OCD, something is called deep TMS, and I do with Neurostar actually. You can do deep TMS with Neurostar, but it's kind of a little bit hurting the patient for OCD. It's called dorsomedial prefrontal and or frontal cortex. With addiction, there's a different location again with just the left side. So there is different location. There is a review article. It's a nice article I would actually share with you guys about what is the most evidence for each location and why.
There are many publications denoting that BGNF increased 6 months after ECT sessions. Thus, it may improve neuroplasticity. Yes. You said that there is no improvement in neuroplasticity and with the use of ECT, but there are many publications denoting that.
So BDNF, so we agree BDNF is a marker for neuroplasticity, right? We agree about this. Let's put ECT as like the gold standard, but also TMS. I'm giving the idea to patients or to speakers who doubt TMS. If TMS is just another light therapy or just like a fancy chair, patient actually responded to TMS that failed ECT in the past. ECT actually, the mechanisms of action are unknown until now. There's some like increased hormonal biomarker with ECT, but unfortunately, there are no clear mechanism of action for ECT. And I know if anyone knows the clear mechanism of action for ECT, I will be happy to learn, because I don't know what ECT, how it works. So ECT, yes, it has some increasing biomarkers, but we don't know how. That's really still under investigation. But absolutely, ECT, the most effective tool for depression, even for MCQ questions, for imtihanat, when we ask a student, what's the most effective for depression? We have fluoxetine, ECT is the right answer, right? It's a tricky question. Usually we ask, what is the most effective? So ECT is the most effective. Unfortunately, it does not last. يعني احنا بنزيد عيان بيجي مرة واثنين وثلاثة after ECT and we fail ECT.